Good morning. Thank you for joining us for our KHC Office Hours today. Today is Wednesday, February 23rd, 2022. This monthly series is predominantly in support of Kansas hospitals, particularly those participating in the Compass HQIC, yet all are invited to attend. We welcome everyone who has taken time from your busy schedules to be here with us today. We have prepared a handout for you of today's presentation, and a link was included in your Zoom webinar reminder this morning. We have also placed a link in the chat. For sound quality, everyone is muted at this time other than the speakers. We do have the ability to unmute lines as needed later in the hour. This session is being recorded, and we should have a link posted to our KHC Education Archive later today. We are using Zoom webinar platform for our virtual sessions, and we encourage you to locate the chat and the Q&A features on your screen. Please use the chat feature to let us know where you are joining us from and to add any comments for discussion. When using the chat, please select all panelists and attendees so everyone can see your message, not just the panelists. If your message is only for the presenters, please select all panelists. The Q&A feature has a special role too. Let's use this feature to pose any questions to the presenters. I believe that only the presenters can see your questions that are typed in. We can either field your questions during the live Q&A time, or we can respond in writing. So let's begin with a message in the chat. Please select all panelists and attendees from the drop-down menu and let us know where you're joining us from. Next slide. Here's an outline for our time together today. We are pleased that our featured topic today is effective care coordination to advance the integration of behavioral health across the continuum. We will also provide some general data and program updates. And as always, we will share resources, upcoming events, and next steps. Just a reminder that if there are any questions, please type them in the chat or reach out to us anytime following this office hours. Next slide. Your KHC Compass HQIC team with you today includes Eric Cookweens, our KHC Data and Measurement Director, Erin McGuire, our Quality Improvement Advisor, Patty Thompson, Quality Improvement Advisor, and myself, Heidi Corson, Quality Improvement Advisor. Our special guest speaker today is Dr. Jeff Capobianco, a senior consultant with the National Council for Mental Wellbeing. Next slide. Before I turn it over to Jeff for our presentation, I would like to share exciting new opportunities that we have at KHC. We are now enrolling for an all-new Align All Health initiative for eligible Kansas hospitals that are in the Compass HQIC and that have the KHIN dashboard technology in place. The new Align All Health initiative provides a targeted intervention through June of 2022 for hospitals and community mental health centers to help improve health outcomes and care transitions for high-risk patients with behavioral health needs. A $1,000 stipend is available for up to 66 eligible facilities that successfully participate. For more information, reach out to your Quality Improvement Advisor or see our website. The enrollment deadline is just a few days away on February 25th. Next slide. As I mentioned earlier, our special guest speaker today is Dr. Jeff Capobianco, a senior consultant with the National Council for Mental Wellbeing. He has more than 25 years of clinical, administrative, and healthcare research experience and has consulted with dozens of healthcare organizations, including state departments of Medicaid, hospital systems, and county health departments. Prior to joining the National Council, he held positions as a research investigator at the University of Michigan School of Social Work, where he continues to teach part-time, and as a director of research and new program development for behavioral health managed care organizations. Dr. Capobianco has an extensive background in strategic planning to design and implement primary substance use disorder and mental health care integration models for children and adults. With expertise in evidence-based practice implementation, Lean Six Sigma methodologies, and learning community approaches to organizational change, he focuses on developing sustainable, efficient, and effective approaches to healthcare integration. At this time, I am pleased to turn the program over to Dr. Capobianco for our featured topic.
Thank you very much for that introduction. Come to you from Ann Arbor, Michigan today, where the weather is a little bit chilly. It was 54 today, now we're at 20 degrees. So I'm sure you guys are experiencing something similar there in Kansas. One of the things that wasn't mentioned in my bio, which my employer was nice enough to put together for me, was my experience early on in my career working with community hospitals and large academic health systems or hospitals. Started out in Vermont, actually upstate Vermont, where the University of Vermont had a large regional hospital. And then there were several local community hospitals, and I worked as a paramedic and eventually moved into working in behavioral health. I'm a psychologist by training and got involved in behavioral health through working in emergency rooms and working with the ambulance service. We got into critical incident stress debriefing for police, emergency room staff, fire personnel who were experiencing difficulties after pretty traumatic calls, and eventually ended up getting credentialed to be a psychologist and initially worked out of emergency rooms. So this whole work around care coordination for people with, quote, behavioral health conditions is something not only that I got a long history in doing, but it's really near and dear to me because of the current troubles we're having with the pandemic have just really exacerbated the difficulties, particularly regional small hospitals have in coordinating effective care for people with behavioral health conditions. When I use the term behavioral health, I mean the treatment of people, treatment for people who have mental illness or substance misuse conditions. So today I'm going to talk about some of the practical approaches we've learned in doing work around the country to help with care coordination. Next slide. So I just want to reiterate that if you've got questions, if you came here today, you woke up this morning and, bellied up to your computer to start your day, if there are certain things you wanted to make sure you heard about today, questions you had, things you wanted to learn about, please go ahead and type those in the Q&A in the chat, and I'll take questions as we go. If people want to open their microphone, I'm sure we can do that also if your question's a little bit too complex or long to be able to type out. I'll take questions as I go throughout the presentation because more back and forth I find to be really helpful for everybody. Next slide. So I'm a big proponent of defining terms before getting into conversations with people, particularly conversations that have to do with complex topics like care coordination. So I'm going to briefly define the terms I'll be using throughout the presentation: care management, care coordination, and transitions of care. I tend to use care coordination and transitions of care interchangeably, but I'll get into definitions in just a minute. I think particularly when we're talking about systems linkages and care coordination, it is really important if you're an emergency room lead, if you're a psychiatric floor, or if you're in a small community hospital that doesn't have psychiatric floors, but you certainly have patients that are using your floors that have mental illness, substance abuse conditions, possibly dementia, that if you're coordinating care with an outside provider, that you start by defining your terms, like what are we talking about when we talk about things like care coordination. Next slide. So care management, not surprisingly, discusses a broad array of things that any provider system or any individual provider is doing when they're working directly with a client or a population of clients. And if you look at the list of things you do when you're providing care management, care coordination and care transitions is an important component of that. More recently, due to value-based models that we've seen emerging in the marketplace, we've seen HEDIS and other quality indicators shining a light more brightly on care coordination, particularly for hospitals, with readmissions not being paid for accountable care type marketplaces. So care coordination has become not only a hot topic because of its importance, but has become a hot topic because of the potential impact monetarily on healthcare systems. And we've seen these large ACO systems being more willing to really shine a light on care coordination between provider networks due to that, which is a good thing. But like losing weight, care coordination isn't easy. It's a simple concept, like losing weight. We know the recipe, right? Fewer calories in, healthier calories in, more exercise. You will lose weight, unless you have some underlying medical condition that needs to be addressed. Very simple concept. Executing on it can be quite difficult, as I'll attest to when it comes to the weight management piece anyway. Next slide. So when we look at this term care coordination, not unlike care management, it's an umbrella term. It's a big term. You can fit a lot of things underneath it. And one of the things that we can definitely fit underneath it is this notion of care transitions. Now, when I pull definitions of care coordination and care transitions, a big source, and I source all my slides, so if people want to go find where I got these quotes or these whatever I'm describing in the slides. I also have a resource slide at the end with a lot of links to websites that have really good resources for care coordination. The place where I'm getting most of this terminology is from the AHRQ, or the Agency for Health Research and Quality, which is a federal agency under Health and Human Services. AHRQ is a really great resource for practice-based research information. And in that website, they have something called the Care Coordination Atlas. It's a 300-odd page document that describes what effective care coordination is. And within it, they have a lot of different tools also for organizations to use to better manage their care coordination. Next slide. So if we think of care management as a big term under which you can embed care coordination and transitions of care, transitions of care nests nicely into care coordination. And it's even more specific than the term care coordination because it speaks of a very discrete movement of patients within a healthcare system, whether that be movement inside a hospital from the ED up onto a floor. That's considered a transition of care. You could even consider a transition of care if you wanted to a change in treatment. So you're transitioning an individual patient's treatment from one type of treatment to another. But oftentimes when we think of care coordination, and certainly what we'll be talking about today, is the transfer or movement of patients between settings or between organizations. So in this case, we'll be talking about people with behavioral health conditions who are going to be moving between a hospital, whether it be on a floor, an emergency department, and a community mental health or substance abuse treatment center. I hope you are all aware that Kansas is leading the way in the country when it comes to behavioral health through its creation of a certified community behavioral health clinic model. Kansas has developed this model based on a federal demonstration that occurred in 2015 and it's been kind of rolling out since then. And what it requires of all certified community behavioral health clinics, of which there will be many in Kansas soon, it'll be kicking off in the spring, where these clinics will become, quote, certified by the state. Part of the certification requirements is that they have a robust system for transitioning care and coordinating care, particularly with hospital systems or hospitals specifically. So if you are a hospital, which you all are, I would be talking up to your local behavioral health clinics. Hey, what's up with the CCBHC model? What can we do to support you with care coordination? What can you do to support us? This February 25th is the deadline for this project that was discussed at the beginning. I really encourage everyone to sign up for it. I know everybody is dealing with workforce issues. I know everybody is dealing with pandemic, but the work around care coordination can be done even in the midst of all of that. It doesn't mean you have to go gangbusters with it. It can be a light touch. It can be whatever you can get done between now through the spring to really take a look at how to do care coordination and transitions of care better. And that's what I'm going to move into talking about next. 4 steps that I've seen hospitals and behavioral health providers be able to use to really build out their care coordination system. Next slide. So when we talk about care coordination or transitions of care, and again, I'll use those words kind of synonymously as we move through. If you're the patient or the client receiving services or a natural support like a family member, when you think of care coordination, you think is, how is this going to make my life easier to get care? I have a eye condition, and recently I'm getting a second opinion on some treatment, and I called this new provider that's going to be doing a second opinion for me, and I spent about an hour trying to get my medical records over to his office. And people were very nice and everything, but it was obvious, they weren't going to really take on that piece unless I was, pushing it. So that was an example of me as the patient needing to coordinate care. And we want to reduce that as much as possible. I think of a good healthcare system as being seamless, where the patients don't feel any of the seams in the quilt that we, sew together between a hospital and a behavioral health clinic. There's a seam there because they're separate entities, but the patient shouldn't have to feel that seam. We're not quite there in America yet. Healthcare is tough, but we can make big strides to get there where the patient and family really don't feel those seams. The healthcare provider asks, how is it easy for me to do my work? If I'm working in an emergency room and I have a behavioral health client that came in intoxicated, has sobered up, was initially suicidal, is not suicidal now that they've sobered up, but clearly has an underlying depression or anxiety disorder driving their substance misuse, I want to get them to a behavioral health provider in the community efficiently and effectively, as in quickly. How do you do that? That can be really hard. Behavioral health providers are not known for being quick to answer questions about how to get patients in or whether they share a common patient with you. Luckily in Kansas, you have the HIE, you have this ability to transfer data pretty effectively, is my understanding, between hospitals and behavioral health providers. So that makes the healthcare provider's job a little easier. But not having a clear care pathway between a hospital and behavioral health provider still can be really difficult, even though data might be easy to share. Actually getting continuity and ensuring that the person actually followed through with a referral to a behavioral health entity can be really hard for the healthcare provider. And then finally, systems representatives, we can call these managed care people, we could call them policymakers at the federal or state level, taxpayers, you and me. What we want to know is the money spent on care efficient and effective? Are we coordinating care in a way that's efficient and effective? And do we have data to provide evidence of that? Next slide. So when we look at who is most likely to be readmitted due to poor care coordination, I don't think I have to tell you, these are our usual suspects, and these are the usual system conditions that lead to these suspects, quote, these patients that unfortunately need to be readmitted due to all cause issues, meaning there was something that could have been stabilized in the community that wasn't. That's the definition of the HEDIS all cause admission metric. These are things that we know are very common in healthcare today, not just the US, but across the world. Helping people step down from a hospital stay, whether it be an emergency room visit or stay inpatient, integrating into the community with their current provider network, or if they didn't have one, starting them with one, getting their natural supports in place is very, very difficult for the hospital. And if you look at the types of patients that are mostly at risk for readmissions, behavioral health patients are included. People with psychosis, people with substance use conditions are at high risk for being readmitted because it's difficult to coordinate care with them. And then we've got some usual suspects here around people discharged on weekends or holidays can be more likely to have poor coordination. I remember as a clinician working in a behavioral health clinic, whenever I'd go out to see a client, I'd go out to the waiting room to bring a client back to see me when we were doing case management or therapy. And if I saw the My Belongings bag and the bracelet on their wrist, I would say, were you in the hospital? And they'd say, how'd you know? I said, well, you got a hospital ID tag on your wrist still, and you're holding the My Belongings bag you got from the hospital. And that might have been the first time I knew he was in the hospital. Which is not a good sign of care coordination. It's not a knock to the hospital. It's not a knock to my agency, but it clearly shows that when As a clinician on the behavioral health side, I'm learning that they've been in the hospital with the My Belongings bag. It's too late. Next slide. So how do we control for that? For basic practices or principles have really fallen out if we look at how good care coordination is designed. And I'll go through each one of these with some examples. The first is to make sure that you have alignment between the different agencies, and that you not only have alignment in the form of things like care coordination agreements, which we'll talk about, but that you spend the time to talk about shared values, principles, and practices. Now, we'll have a slide in a minute here looking at values and principles, and most of us wouldn't disagree that it's important to have, person-centered care, that you're efficient and effective. That's all very important. None of us would disagree with it, but many times when we're either redeveloping relationships we already have, improving them, or starting new relationships between institutions, between a hospital and a behavioral health provider, we kind of just make the assumption that we all agree on the same thing, just like we make the assumption that we all define things the same ways. And we jump right into planning and getting to work. And not taking the time to look at shared values, principles, and practices can come back to bite you. And I'll talk a little bit about that. Once that's done, really making sure you have good data sharing capacity, and that you have written agreements that speak to shared target metrics that define whether you're doing care coordination well. What gets measured gets done oftentimes. So having good metrics to share with each other and sometimes commiserate over because they don't look good is really important, so that people can own the data, use data as a benign observer of the process, and really go through an iterative process of improving care coordination until it's fully seamless for our patients. That requires step 3, where you map out your current state, you map out your future state where you want to get to, and you use regular good old PDSA or plan, do, study, check, act cycles to get your organizations there to this smooth process of care coordination. This is something that takes a lot of time. You're not going to do it, in 3 months. So since you have the time, it's important to just go slowly with these things. Again, I want to make sure you all know that I'm fully aware of the workforce crisis, and I'm fully aware of a pandemic, and I don't want to come off as Pollyannish as a consultant type, because this is hard to do today. That's why it's important to just go slow and do what you can with the limited resources and limited time you have. And then finally, that ongoing monitoring and continuous quality improvement, making sure that once you've established an agreement, once you start moving patients back and forth in a really structured way, that you make sure you're focusing on keeping that on specification, so that if your care pathways that you've designed go off target, you have a way to go and fix them and keep it sustainable over time. So let's dive into these, and you guys will let me know if we have any questions. Next slide. So values, principles, and practices, again, values are the words or phrases that describe what we care about, what's important to us. And I don't think anybody would disagree with timeliness, effectiveness, measurement, those kind of things. But many times I get into conversations, or I start working with 2 organizations where they agree measurement's important, but they've never really measured their effectiveness in transferring clients or transitioning clients back and forth. And when you say, well, what about measurement? They say, oh yeah, measurement. Well, yeah, well, I guess we should do that, but it's hard. So making sure when you first engage, and it can happen pretty quickly, you don't have to go too deep into it, that you kind of list out what do we value together. One of the things that's really important when we're talking about behavioral health is making sure we value consumer focused, or consumer centric or person centered language. I find a lot of times we have vestigial language, old language we use in healthcare, like calling people addicts, or using language that's a little stigmatizing, particularly around mental illness and substance abuse treatment. So as a value out of the gate, we can start to talk about, well, what language are we going to use when we describe clients that we're serving together? That kind of discussion really starts to expose our mental models and our thinking, and our definitions for how we're defining treatment. Oftentimes you will see in hospital systems, understandably so, very problem focused. They get a solution to a problem. They rank order problems. They start with the top problem. They work their way down. Behavioral health, much more process oriented. They tend to be more likely to talk about all the problems at once as opposed to rank ordering them. And that can really annoy, frankly, folks that work in hospitals. So understanding that out of the gate, what do we each value? What do our cultures look like is really important. And then from values, which are the words that are important to us, you have principles and eventually practices. So our principles are the rules we're going to put together for our agreements for working together. Principles are things like how and when are we going to share data? Which data are we going to share? How are we going to develop this care coordination agreement? How robust is it going to be, meaning legalese? How much do we have to include the lawyers? We're going to be specific on the rules we're establishing with each other to give evidence that we're actually executing on our values, that we're actually practicing what we preach. It's a really good way to start a relationship is to define the values, like what do we each care about? What are we each stressed out about? What keeps us up at night? And then where do we want to go about unpacking a plan or putting some principles and practices in place together? Next slide. And luckily, there's no, one place you have to start when you have those conversations. I've worked with lots of organizations that are starting care coordination and they're like, what we really need is just somebody to call when we have a psychotic or a really drunk client because we don't know where to refer them to. Most places don't answer our calls. We just need somebody to answer the phone. That's a great place to start. You can start with something that simple when you're designing these agreements. And oftentimes when you see organizations beginning their care coordination journey together, if I might be so flowery, there's kind of a three-stage process. The first is they develop one-off referral processes. And a lot of these times, these referral processes are driven by a crisis. So I'm working in an emergency room, or I've got a patient on a floor that I need to discharge to a behavioral health provider because they have significant behavioral health needs. And I work with their natural supports. I start cold calling, or I work from a list of behavioral health providers I've been given that we often refer people to. And you just begin as a clinician, a social worker, a nurse, a prescriber, working to get this patient to somebody, get an appointment for them somewhere so that you can feel good about finishing your discharge documentation. So these are one-off referral processes. We're recreating the wheel every time that client is in our midst. Sometimes we're sharing data, and that usually requires that the client sign a consent, and then we do the back and forth consent process. It's pretty onerous. So that's kind of the level one. Level two is the informal referral agreement. This is where you've got two provider systems, a behavioral health provider and a hospital, and maybe the nurse lead in an emergency room and the clinical lead at the behavioral health center have started talking. And they've talked with each other and they say, well, how can we make this easier on each other? We know we have clients that end up in the emergency room there, and our clinicians get annoyed when those clients show up in the waiting room with the My Belongings bag. How can we help my clinicians know if somebody's been in the emergency room or up on a floor? Likewise, the emergency room's like, well, when we have your clients, we'd like you to talk to us when we ask you if they're your client and not say, oh, HIPAA won't let us tell you if they're a client of mine. Again, luckily in Kansas, it sounds like you guys have that data sharing ability that's more robust than most states. So the second level is an informal referral agreement. Typically, two middle managers are talking, and they agree to come up with a rapid way of sharing information and referring clients back and forth. Sometimes a behavioral health clinic will allow a rapid access where if you call me, I'll make sure we get that client in within a day. Or a referral out process where, hey, if we got a client who's in crisis and they need to get to the emergency room, how do we best do that? And the ED says, well, if you've got a psychiatric emergency, we'll serve that like we do any emergency, but if you call us, we'll make sure our social worker is ready to go, or our psychiatrist, or what have you. Individual consents are often needed to be signed. There's no shared consent agreement typically at this level, but sometimes there can be. And then eventually, this may include some way of closing the referral confirmation loop, whereby if I refer somebody to behavioral health, you'll let me know if the person shows up. HEDIS has been playing with adding a metric of, particularly for substance abuse treatment, that hospital systems or any healthcare provider will be responsible for ensuring that a person referred to a substance abuse treatment entity gets confirmation that the patient made the first 2 substance abuse treatment appointments. So this is something we're going to hear more and more about through these value-based market changes, but also through HEDIS. So ensuring that the person actually made their appointment that you referred them to, whether it be, to the emergency room or coming out of the hospital to a behavioral health provider, is really important. And the only way to do that is with data and with ongoing care coordination meetings. So this is something we really encourage be written into your agreements, that you, the hospital, and the behavioral health provider will meet regularly to discuss complex patients that you both worked on coordinating care with, and that you will actually review the data that you have around how many patients were seen, where they were discharged to, and how that all went. Now, it doesn't mean you need to meet weekly. Maybe you will as you kind of build up your relationship. Sometimes hospitals will meet quarterly with a behavioral health provider. It can be quick, it can be virtual, but the important thing is that the meetings are happening, data are being reviewed, and that your values and principles are being followed through on. This allows you to have those CQI or continuous quality improvement protocols in place, so that if you do have a train wreck that happens, something happens where somebody's referred, the patient never makes it there, they become suicidal, the police get involved, you can kind of look at, well, where was the gap? How could we fix that gap and use the CQI process? Finally, the highest level is the one where a hospital and a behavioral health provider have a business, you can call it a business associates agreement, a memorandum of understanding that the lawyers have looked over. Typically, when you include lawyers, which I agree you should, it does add time to things. So you can come up with informal referral agreements between middle managers, between leaders of a hospital and behavioral health clinic, as the structured legal document is being created, so that you don't have to wait for it. I often hear from behavioral health and ED as well, yeah, we're working together, but we're waiting on, getting approval of the business associates agreement through legal, and that could take 6 months to a year, and we're just not doing anything in between. And that's really, it doesn't make any sense, because there's a lot of work you can do while you're waiting on that. A lot of times these legal agreements, but not always, are like policies. They're very high level. They don't say a lot as far as the care pathways or the individual workflows that staff working at the hospital patient level and the behavioral health clinic level need to do. Some agreements will build that in. I often think of these business associates agreements as being like infection control policies. Your hospital has an infection control policy. If you go look at it, it's pretty high level. We will train staff, we will ensure we monitor infection, we will have spill kits, but it doesn't get into the details around where the spill kits are, how to take your gloves on and off if you've got blood on them, which staff are going to be trained when and by whom. That level of protocol oftentimes isn't at the policy level. It might be built into it, but it's something you can play with, that protocol level. The policy doesn't change, but protocols often change. So many times with these business associates agreements, the protocol level, how is it going to look on the ground, can be worked on as they're playing with the legal language around how data are going to be shared, and what the relationship is going to be between the hospital and the behavioral health provider. But ultimately, having a business associates agreement, having protocol that describes the pathway the patient's going to move through as they move between your agency and theirs, is really what you're shooting for. Next slide. So in developing that, and again, stop me if questions come through. In developing that, measuring the transition is really important. And we have a whole menu of options as it relates to measuring care coordination and people moving between entities, or landing at a behavioral health clinic. And this is the usual suspect here. The ones I want to the usual suspects. The ones I want to shine a light on are number 2, this transition planning and making sure that you have care transition meetings going on, particularly if someone is on your floor. This is less able to do if someone is in an emergency room. But if you have a patient on the floor, making sure that wherever you're going to be discharging that patient to, that there's a care transition meeting between the provider at the community mental health clinic and the hospital. And I'll show an example of a workflow that a client I was working with developed to ensure that that happened. For emergency rooms and for hospital floors, making sure that you have regular care coordination meetings between staff. And the usual things here around CCDs or care coordination documents, making sure that data are being shared back and forth. HEDIS measures like keeping appointments scheduled within 7 days of hospitalization. Monitoring those data can be very important. But as I think many of you probably know, the HEDIS measure of 7 days of post-hospitalization seeing a provider in the community is not a good metric. The research showed if a patient is discharged from the hospital to a behavioral health provider, they need to be seen within 3 days. The reason why HEDIS said 7 was to give everybody some grace, but the evidence was very clear in the research that if you don't see a behavioral health client within 3 days of discharge from the hospital, they are at a very high risk of no showing to the appointment you did give to them and a very high risk of readmittance to the emergency room or the hospital floor. Next slide. Once you pick your data, and again, you can start with one data point and then kind of build from there. It's important that people on the hospital side and people on the behavioral health side have access to the same data and that they're monitoring this. And this is just an example of a dashboard that a behavioral health clinic I've worked with used. It tracked when people were admitted to the hospital and discharged. So when they were admitted, they got a notification, so they knew somebody was on the floor or in the ED, and they got notification when they were planned to be discharged, which allowed them to have a care coordination meeting and give evidence of that, and then the 7-day follow-up appointment, whether it was scheduled and kept. So just simple metrics like this are not simple, right? They're hard to track and stay on top of, but if you can develop the principles and the values to actually get it done, it makes everybody's lives easier. I understand through your HIE that you guys have dashboards that have these data, which is huge. So the behavioral health clinic and the hospital simply has to log in and look at these data because they are available to you, which is awesome. Having data as a benign observer to your care processes is really important, and making sure that clinicians and supervisors of those clinicians are readily going to the data to do your population health management and to track whether coordination happens seamlessly is really important. Otherwise, you're flying blind. Next slide. So step 3 was mapping your current state and developing a future state to shoot for. And this is just an example of a community mental health clinic that was working with, and this was a community hospital, where they wanted to better nail down discharging clients to the behavioral health clinic from the inpatient floor. And what they did was they did a Lean Sigma process where they developed swim lanes, and they call them swim lanes just because this looks, if you look at this graphic, it looks like you're looking down on a pool with swim lanes. And each lane had the role of the organization. You can break this down by individual staff roles. You can get as detailed as you want to with this Lean Sigma stuff. But they kept it pretty simple here, where the top swim lane they had for the hospital itself. And the first step was if they got a patient on the floor, they would check to see if that patient, quote, belonged to one of the behavioral health clinics. And if it did, that would trigger them reaching out to that behavioral health clinic to say, we've had Joe client admitted here. And that would also trigger a care coordination meeting. And you can see the steps they went through here. Step by step, they describe what the best practice for them is going to look like. So this was their future state, and they shot for it, and over time would go back to it and tweak it and find well, this didn't really work. We need to make this step a little bit clearer, or this was too much. Let's back off. And they went through this process and ended up with this care pathway for people transitioning between their organizations. Importantly, with this slide, if you look at the numbers, each number, they had like a half page or a 1-page bullet pointed kind of guide that explained what would be done for each one of these steps. So if you looked at this as the cover sheet, you flipped it up, you would see each number and kind of the steps for what that agency and whose staff in that agency would engage in to make sure this process was smooth. And if you really get Lean Sigma and detailed about it, if you go from left to right is the time scale. So you can actually look at the average time it takes to actually do this and look at the average time clients are in the hospital, the average time it takes for the first care transitions meeting, the average time it takes to alert the behavioral health provider that one of, quote, their patients is on the floor. You can also do costing because every step of the way involves staff doing work. So if you put a time to each step and you knew their salary, you could actually cost out the price of doing this kind of care coordination. So getting to this level of detail gives you a lot of not just insight, but hard data as to what it costs and how much time it takes to coordinate care in this way. The current state is where you start because you want to make sure that you at least give yourselves credit for what are you currently doing. And maybe, quote, all you're doing currently is, well, when we've got a behavioral health client, we try to refer them to our behavioral health provider in the community. And then the next morning, say they get discharged from the ED that evening, the next day we'll call and let them know the client was there and see if they actually followed up. That's great. I mean, wherever you are planning to go, you have to first know where you stand. And the current state of how you do coordination is important to define. And then from there, you can set off in your journey to that future state that you want to get to. And again, this doesn't have to be done in 3 months. It takes time. Everybody's really busy. If you've only got 15 minutes to spend time on this a week, then make that the best 15 minutes you can to work on this care coordination project and get it done. It does not mean you have to stop everything you're doing because you're all very busy to focus on this care coordination process. Take it through small bites. Next slide. So in closing, this process, as I started, was very much focused on defining where language is, where we all stand, so we're all on the same page, defining what our values and our principles or the rules we're going to use to act together are, choosing a care coordination approach that includes data sharing and putting that into some sort of an agreement, starting with a really basic agreement. It might just be a verbal agreement that, hey, we'll work together, moving to a more formal legal agreement that includes a memorandum of understanding or business associates agreement, and mapping the current state process and the future state where we want to get to that really looks at all of those gaps that we want to fill. Once you get that there, you have to keep it alive. You have to nourish the process. And a lot of times what I see happen with care coordination between hospitals and behavioral health providers is that you've got a champion in the emergency room. It's an ED nurse who's just awesome, and he or she gets it, and she's been leading the charge, and they leave their job. And either that or on the behavioral health side, same thing happens. Oh, that supervisor used to run that, now got promoted to a new position. And the care coordination process dies because the relationship died between those two people. That is very, very common. And the way to control against that is to really map things out and to make sure that you have protocols written, that you have a care coordination agreement, and that you meet regularly. That's a really important. The care and feeding of relationships requires that people share their faces. Unfortunately, today it's typically through Zoom, but eventually it can be face-to-face, I hope. And make sure that you're reviewing those protocols and holding yourselves accountable to the values and the principles that you've established for yourselves. Make things clear in job descriptions as to whose responsibility care coordination is. Oftentimes care coordination is just a good idea, it's an afterthought. It's not really clear that as the lead nurse in the ED, it is my job to make sure that somebody gets an appointment if they're discharged from us after having a behavioral health event, that they get an appointment. That is my job. It's not the social worker's job, it's our job. So make sure that in your job descriptions, that's really clear what care coordination looks like. Make sure in supervision that you're talking with your staff about whether they're doing care coordination well or not, and being able to kind of quote police it, to hold them to the principles and the values you have as it relates to care coordination, and give them the training they need to actually execute it on it well. Educating your consumer and natural supports about their role in care coordination. If mom or dad agreed to take someone to an appointment, then we need to probably call mom or dad and remind them that they were going to take that person to an appointment. Care coordination isn't just the responsibility of the care provider. The patient and their natural supports have a role in this. That's the only way we can get this work done. Making sure you have reasonable, clear targets to monitor and hold yourselves honest to each other, and include dashboards for that. Do the mapping and revisit that mapping on a regular basis to make sure that it's working. A lot of times people will spend the time to map out their care coordination, their care pathways. And then when stuff hits the fan and it's not working, they forget to go back and say, well, we mapped it out. Let's look at our map and pick some areas where we think there was a breakdown and focus on doing a PDSA on that specific area. There's a mapping tool which Erin will send out that I encourage people to use, particularly once you get your care coordination going well between your behavioral health provider and your hospital. You can use this mapping tool to start looking at other agencies in your community that you want to do a better job of coordinating care with. And this includes everything from government entities to social service agencies, homeless shelters, food pantries. If you map out all the providers in your community with whom you should probably be coordinating care more effectively, it gives you a nice picture of where you stand and allows you to pick some targets of where you want to take a journey to, where you want to, your future state you want to create. So doing that is really important. And the tool I developed is just an Excel spreadsheet, but it includes a lot of different entities you can pick from. And then it has some metrics in there that you can go to this entity and say, hey, we want to develop a relationship with you, and we want to start measuring our relationship and our way of care, coordinating care with shared clients in this way. So it gives you kind of a nice step-by-step process to do that. And then finally, you know, at least annually, if you've got a business associates agreement, things are humming along great, at least annually, pull out your business associates agreement, pull out your care pathway protocols, job descriptions, and just take a look at them. I'm shocked at how often behavioral health, primary care, hospitals don't look at their business associates agreements. They don't look at their contracts with managed care and really look at what they've committed to and what the managed care or the collaborating entity has agreed to. In that document, you'll find a lot of things that you have to be reminded of. So at least annually, pull it out and read it. And if you need to tweak it, but at least annually, in one of your regular care coordination meetings, make sure you put on the agenda to look at your agreements and to look at your mapping. The other time to really take a hard look at it is, again, if your metrics are starting to fall out of specification. If care coordination metrics are looking bad, people aren't making appointments, appointments aren't being made, you are finding that you didn't know a client was in the hospital when they were discharged to you, those are all indications that you just need to revisit your care pathway process. So with that, we've got a little bit of time for questions. Any questions out there or comments? Feel free to throw them in the chat. And if we don't have any, I think we have another item we need to discuss anyway. But Erin, did anybody come through with a question or a comment?
We have not had any questions yet, but as Jeff said, if you do have any, please feel free to put them in the chat. And I guess with that, we will move on to Eric's portion of the presentation to review some data.
Great. Thank you, everybody, for your time. And here's some more resources. that if you want to click the links, there's a lot of good information on care coordination there.
Thank you.
Great, thanks. So we've, KHC staff along with KHIN staff have been working with the National Council on Mental Wellbeing and with Jeff and his colleague Joan. And I just want to thank Jeff for the great help you've been and for your expertise and for sharing it with us and for giving us a really great presentation this morning. Really excellent job. So thank you, Jeff. So next slide, please. I'll be pretty brief with my updates. We've got a couple of things to mention here. Again, for HQIC, data are due every month for the month of, due at the end of the following month. The administrative claims and NHSN transfers happen once a month. Our current data refresh is February 10th. And here's the announcement for March. Our data deadline is a little earlier than usual. So we're going to be pulling data around March 4th. And the reason why we're doing that a little bit early this month is because we have an important evaluation time point for the HQIC program, for the Compass HQIC program. So please do try and get your data in by the 4th of March. Next slide, please. Also, as part of this evaluation time point, we're taking a look at a few measures, trying to just increase our reporting enough to meet their threshold for this important evaluation time point. So you may be receiving an email or two in the next week or so asking for data in case it's missing. And importantly, what we're really looking at right now is are the infection measures that would be reported through NHSN. So if you get an email from us, we'll ask you to, if you have the data, but maybe you haven't been in NHSN for a while, maybe actually go into QHI and key that data in just for this time point. Of course, NHSN is our official data system for those measures, but so be looking out for that email. It'll be coming in the next week. Data completeness reports will be coming out, or I guess we sent them out last week, I think, and then we do that pretty soon after the data snapshot. We fixed a problem where the certain claims measures were being marked as yellow, but actually it was just because there were no discharges that month. So we fixed that problem. Snapshot reports also went out a couple weeks ago, and when we do them in March, they might look a little bit different. So be looking out for updated baselines. They've changed the way that we define baselines for HQIC, and that's also related to this evaluation time point. Next slide. Really briefly, I just wanted to mention we're looking at our monthly HQIC data every month. And when something interesting happens in that data, I always want to share it with our network. So something interesting has happened with the all-cause 30-day readmissions to the same hospital measure. What I did here is I used our new baseline time period, which is 2019 January through August of 2020. So that the red line to the left is our baseline, and I put the median percent readmissions for the baseline as the dotted line that goes across the chart. And if you remember, or maybe you haven't looked at the run chart rules in a while, we actually have a shift right now, which is more than 6 points in a row below the median. So I'm not exactly sure what's going on there, but our baseline median was 6.6%. And if you actually look at the last 6 months, it's below 5%. So that's a really good sign. I'm not sure whether it's related to the Omicron wave or what, but we'll be looking at that moving forward. So that's at least something to celebrate. Next slide. And I have two very quick slides from our colleagues at the Kansas Hospital Association. There is a QHI training session if you need one, actually tomorrow from 1 to 2. You can sign up for that with the link there. Next slide. And just really quickly want to plug a new product that the Hospital Association is working on. We're in the final review stage of this document, but it's a resource guide for quality reporting for critical access hospitals, and I think it'll be really useful, especially for new quality directors, which we tend to get a lot of. Next slide. And I think I'm passing it to Erin.
That's right. Thanks, Eric. Appreciate it. I know we're nearing the top of the hour. Just a couple resources, updates, and upcoming event reminders as we close this morning. The first one here, just a reminder to get your 2022 updates made to your quality improvement work plan. Thank you to those who have already submitted your updates. We really appreciate it. If you do need assistance with updating those or just brainstorming some new goals that you want to work on, please reach out to your QIA, whether it's Patty, Heidi, or myself. And then we are asking that we can get the updates made and submitted to your QIA no later than March 4th. So that's fast approaching. Reach out if need be. Next slide. Thank you to everyone who's registered for our 2022 office hours. Our next office hour is scheduled for March 23rd. Rhonda Spellmeyer from KHIN will join us. She's going to give us a review of the KHIN dashboard and the acute alert tool. We encourage you to invite your team to participate in this live virtual event. As always, it'll begin at 10 a.m. And then just remember that all of our sessions are recorded, and then we do post them to the KHC Education Archive. Next slide. This is just a quick rundown of upcoming Compass Network education. March 4th, we have our next session in the Learning in Action series that's hosted by Dr. Amy Botwell, the Aspire to Reduce Readmissions. Remember that we cannot record those, so please join live if at all possible. March 8th, we're going to explore some strategies to opioid morbidity and mortality. And then on March 28th, we're going to talk about pressure injury prevention for 2022. We are working on some CLAPSI education as well that is hopefully soon to be released. Next slide. You may remember our guest last year during, I believe it was our October office hours, Rachel Duncan. She's going to join us again on March 8th for a Compass-wide event. This is exploring strategies to prevent opioid morbidity and mortality. Next slide. And then Jackie Conrad is going to be our featured speaker on that March 28th event, Pressure Injury Prevention for 2022, Building Adaptability and Reliability. You can see today's handouts for registration on all education events that have been announced. Next slide. And then just a reminder that we are still inviting eligible hospitals and clinics to participate in our 3rd annual Overdose to Action project. Up to 8 eligible facilities will be accepted on a first-come, first-served basis. The project is providing excellent support and will run through August 2022. You can see our website or contact Mandy Johnson for additional information. Next slide. As you leave us today, make sure that you're staying up to date on your data entry. As Eric mentioned just a minute ago, we are entering a critical HQIC evaluation time period. If you do receive an email from us asking for some missing data, please respond as soon as you're able to. We want to make sure that you're reviewing those 2022 work plans, updating your hospital goals. Again, reach out to anybody on our team if you need help with those. And then don't forget to take a minute and log on to iCompass and iCompass Academy to engage and learn alongside your peers. Next, Compass Navigator will hit your email on March 1st. Lots of learning opportunities will be announced, and as always, links will be available. This is just a slide with quick contact information for our KHC team. Once the webinar is over, if you have a question, please reach out. And I'll pause. We got about 1 minute left. If there's any questions, we can answer those now. I'm not seeing any, so I'm going to run through. Thanks for joining us. A special thanks to our guest, Jeff, today. Excellent, excellent information you shared with us, Jeff. As you leave the session, you will be directed to a brief survey. We invite you to let us know what a key takeaway was from from today's event. And then on behalf of our entire KHC team, thank you for your time this morning. It's always great to spend an hour with you. Have a great afternoon, and we will see you all next month.